Hi everyone, welcome. Whoops, let me just go back to the first slide. So thanks for joining. So I'm Farah, one of the cardiothoracic fellow here in Toronto. As maybe my accent kind of betray me, I'm not actually a Canadian. I'm from France, and I came here to do my cardiothoracic fellowship. So I'm just like gonna discuss with you how it's why to do a fellowship, what to expect of a fellowship, and what basically it's like to do this cardiothoracic fellowship in Toronto. And just feel free to ask whatever question that comes to mind, because maybe I have forgotten things that might interest you, and so just feel free to ask whatever you want. So basically, why doing a fellowship? My personal feeling is that at the end of the residency, well, you have like all through all your rotation, you have like a kind of a spectrum of skills, but it's basically to kind of go more in depth in a subspecialty that you like and that you want to subspecialize in and get like real to be more confident and to have real expertise in that particular field. So just to further develop your skills that you have at the end of the residency and to really go in depth in one subspecialty. So the fellowship is great. It's a great place to that, because it's kind of a transition between you're not a staff, so you don't have like the real responsibility of signing out and just to validate, and you're still like in a process of learning. So that's a good in between stage, and a good place to see good cases and to just improve your skill and feel more comfortable. And at the end of your fellowship, I guess you're like kind of ready to go to the next level and next step, because you've acquired the skills that you're developing through your fellowship. It's also for the one interested in research. It's a good place to do some research. Personally, I like research, so it's also an opportunity to develop a research project and to conduct and be part of a research project, and being with mentors that will guide you through this research process. It's really also a good point on a research perspective. And also from more like a personal and also interpersonal point of view, for yourself, well, you would get more confident. So that's always comfortable to feel more confident when you have like rare cases, or when the text calls you and asks you something, you will be definitely more comfortable. And also it's a good place where you can exchange your feelings with your co-fellows, with the staff, and to learn from each others. Like you learn from the staff, you learn from your co-fellows, but also you learn also from the residents. I know that we have many residents, and when they want to come and just I kind of show them the nice cases, and I also like to share this knowledge. So it's a good place for that, and also have some interaction and also make some connection, because you will see in your fellowship you will have some fellows from all over the world, and that's really nice to see how life and how medicine is in other countries. And I know that with my co-fellows, we are currently 8 fellow in the cardiothoracic program, and we have Canadian, but we have Germans, we have Irish, South Africans. So it's from Brazil also. So it's really personal wealth to see how in other culture how you would do not only the fellowship, but also like everything in the specialty in your subspecialty. So how to achieve all these goals of fellowship? it's well, the fellowship is a good place for that, because you would be in a, as I was saying, like in a comfortable environment and a favorable environment. I mean by that, in a university hospital, you would work with like experts in the field that are really specialized and see only cardiac or only chest. So they have really like this expertise, because they are basically just focusing on this field. So you would learn from the best, and from all their own experience. They will show you like nice cases, rare cases, and at the end you will say, okay, well, I thought that was rare, but now it's kind of normal, and I would be confident to raise this diagnostic, for example, by seeing just a CT, because you would say, okay, well, I saw that during my fellowship. So it's always nice for that. And also you will learn through all the rounds that you will have to attend. So it's a good opportunity to exchange with the referring physician, with the clinicians, and to see their own perspective from the clinical point of view. And with all these rounds, I guess you have to see it more as an opportunity to exchange, just like we have so many rounds. Now see it as an opportunity to exchange with the clinicians. So it's always good. And also from research perspective, you have this research project, but also you will have to do some journal club. So you would have to present some articles, and also just when you, for example, go to a congress, you will have like to have a feedback about this congress. So it's always a good learning environment. And as I was previously saying, also by communicating with the other, you will just improve your knowledge, and yeah, get more independence. That's what I meant by being more comfortable at the end. And you will the staff will see at the through your fellowship, and that you're getting more comfortable, and they will give you more and more responsibility. And so it's always good to become independent, and to become comfortable. So more practical, how is the cardiothoracic fellowship in Toronto? Well, it's from 8 in the morning to 5 p.m. Yeah, you work the entire day. At noon, usually you have rounds, whatever round it is. Basically, when you choose the cardiothoracic program in Toronto, you have 6 months of thoracic and 6 months of cardio. If you choose the cardio program, you would have 9 months of cardio and 3 months of chest. And if you choose the thoracic one, you would have like 9 months thoracic and three cardio. So that's I guess 6 and 6 is a good balance, to be honest, to have like a good oversight of both specialty. And so for both thoracic and cardio, you would go through all the protocols. You would protocol all the patients, the outpatients, the inpatients, and then you would just basically report. And with depending on the staff you are with, you will review with the staff, or the staff will review and give you a feedback saying, okay, I just like change that on your report. So it really depends on the staff and their own way of doing it. And that's also nice to work with different staff, because you see also how some staff like to go into details in their reports. Some other would like more the full picture. So it's always good to take the good and the things that you think it's more your own way of doing it, by seeing the different ways of the different staff. And also you have, from an academic perspective, you have one academic day per week on this cardiothoracic fellowship to conduct your research project. So it's always good. And you have also some teaching rounds. For example, we have weekly citywide cardiac lectures. Also on because we have lots of congenital heart disease here, we have some surgical and post-surgical congenital lectures. So it's really real nice. You get 20 days of vacation per year, additional to the for the Christmas and New Year. And you have 5 days of presentation. If you have to go to a congress or present one abstract, you have 5 days. Then the difference between thoracic and cardio, on the thoracic side, you would also do all the biopsy. So for the one who likes the biopsy, it's a good learning environment. We do approximately 3 to 5 every morning. And then in the afternoon, you just, after the biopsy, you go back and keep on reporting. We do a lot of CT, not much the thoracic MRI, and lots of plain films, obviously. And yeah, different types of rounds, respirology rounds, combined rounds, and quality improvement rounds. For the cardio, well, you don't have any procedure. So you have the CT, coronary CTs, the TAVIs, and you have the MRI. So it depends of the week. You can be full week CTs, full week MRI, or just half-half. What you have to do is monitor the quality of the cases. For example, if you need extra sequences, especially in the inpatients, and also if the text called you and wants to have your opinion on a case. And also you have to give the beta blockers for the coronary CTA. So it's kind of not the best part, I would say, of this being in the CT cardio, because you keep, where, for example, you're doing a report and then the text calls you and say, okay, we have the patient on the table, need to give the beta blockers, so you have to go over and give the beta blockers, but that's how it is. And for the rounds, mainly here in cardio, we have the congenital round, which is a kind of a long round to prepare. And yeah, that's it. I guess that was my last slide.
My name's Jason Seidel. I'm one of the body fellows here in Dalhousie in Halifax. My slides are nowhere near as robust as Farah's, so I apologize in advance. I wasn't sure if there was a need for a disclosure side, but I am not important enough to have disclosures, as evident. So as far as the body imaging fellowship goes, I find that it's a very work-related fellowship. Some other fellowships are as well, but it's folks, or what I mean by that is that a general day is like, I'll sit down, I'll whatever staff I'm on with, I'll go through their list top to bottom, dictate along as if it was my report. I send it to staff. They generally just sign it off, and that's it. With some of the more complex modalities, MRI, things like that, sometimes there'll be one review session throughout the day, but generally speaking, it's just like it's my own list. If there's any major changes, then we chat about them afterwards, but generally speaking, it's kind of expected that I'm going to come in, sit down, and be able to work through most things on my own. The caveat to that being that it's not to say that if I have questions, I can't go ask them. It's one of the great things about there being somebody else on the report. If it's something that I want confirmation on or other things, I'm free to walk in and say, hey, this is what I think this is. Am I wrong, or am I crazy, or is that right? One of the various things, or the things that I find it focuses on for body post-surgical or really complex post-surgical abdominal cases, post-Whipple cases, things like that, things that make you want to end yourself on call. HCC screening and subsequent diagnoses, things like that, and then cholangios, which are just a pain to find sometimes, which you can go through CTs, MRs, backwards, forwards, and still it'll be a vague, subtle area of T2 change or something like that. So getting more experience and more hands-on with those, I found, has been really helpful, especially for detection of those things. Other things that I didn't mention there, but things like CT colon, CT enterographies, things like that. A lot of the focus so far has been predominantly CT and MR. There have been a couple ultrasound days, but mostly MR. So as has been kind of alluded to before, why do a fellowship? So interests in progressive learning, focused learning on usually a different specific subset within radiology. One of the main reasons I've found, or other people can correct me if I'm wrong or agree if they disagree, but is working in an academic center. So most academic centers want you to have a fellowship for hiring purposes. That's not to say all positions, but it's a general rule of thumb. That said, as a shameless plug, I have a job back in community radiology, which I think is amazing, and I enjoy getting to see multiple modalities all the time. And most community radiology positions don't require fellowship. Specifically, why do a body fellowship? Again, you're interested in body topics as a focus for learning. Most of the things we discussed, or I already mentioned. Body's generally a workhorse modality. Like this is, of the majority of your inpatient work, it's either going to be body or neuro. I mean, there's other things too, but common things being common. There's a lot of, while there is a lot of straightforward body pathology, when it's not straightforward, it tends to be helpful to have some sort of, specific insight, specific information that you can add that might help surgeons, might help change surgical planning, or, like, or as was discussed, like you go through multidisciplinary rounds and you can provide certain insights into why certain things are causing certain pathologies are presenting certain ways, etc. Ultimately, wanting to do fellowship came down to two things. Do I like this discipline enough that I want to do it forever? Or do I want a job at XY Center enough that I want to do this, that I want to do XY modality forever? Some fellowships do offer combinations and cross-training. Originally, I think one of the ones that I was originally looking at was a body breast fellowship, but you can usually do body breast, chest breast, cardiothoracic, other things. The other thing too is that a lot of fellowships will let you do certain or within reason, certain additional things. Like I'm adding on a month of breast because in the community practice where I'm going, they're going to be reporting mammograms. So it makes sense to be able to do that. And so when I came to them and I said, look, I'm happy to do body fellowship, but can I add on this specific thing at the end? They were like, sure, no problem. So I mean, as long as it's different from residency, there is some discussion and some back and forth that you can take from it.
My name is Mike Fry. I'm one of the nuclear medicine fellows here in Halifax. I'm just going to talk briefly about nuclear medicine and why you may be interested in that. Just as a quick overview, just quickly talk about the nuclear medicine fellowship itself, some of the knowledge and skills that you will gain over your course of time in nuke med. I'll give you a little rundown of what it looks for a typical day in the life of a nuke med fellow, and then talk about some of the pluses and some of the negatives of doing a nuke med fellowship. So in terms of nuclear medicine itself, there's a variety of ways that people can get into it. It's kind of unique in that it's actually a direct entry residency in Quebec. And then across the country, there's a couple programs, Dell being one of them, that have integrated programs, which is kind of like a built-in fellowship to the radiology side of things, which is what I ended up doing. And then a number of other universities across the country have kind of post hoc, post-radiology fellowships, such as the University of Toronto. It's also kind of unique in that a lot of the fellowships are actually 2 years instead of just a 1 year add-on. And the other thing about nuclear medicine is that typically people will write both the diagnostic radiology, obviously, and then go on to write the nuclear medicine Royal College exam as well, which can be a lot of work, but it does lead to dual certification and makes you a bit more marketable. And it is kind of variable across Canada, whether you actually need to write the exam or not. I know in the Maritimes, there's a fair amount of flexibility. For example, there's people in New Brunswick I know that are reporting PET despite only having the FRCPC in radiology. But when you get to the bigger cities like Toronto or out west, it's probably expected that if you're going to be doing things like PET, that you're going to have both certifications. In terms of the knowledge and skills that you'll learn over the course of a nuke med fellowship, there's a really strong focus on physiology. And when you combine that with doing a radiology residency, you basically become the expert in understanding anatomic and physiologic imaging. I know we talk about this in radiology too, that you kind of have to know a bit about every single specialty. You need to know a bit about gynecology, you need to know a bit about orthopedic surgery, you need to know a bit about obstetrics. And that's especially true in nuclear medicine because you're not only taking the anatomical side of things, but you're also adding on the physiology side of things. So for example, I'm studying for my second Royal College in nuke med right now, and I was looking at the Krebs cycle this morning, which is something I swore I would never do again after the last time, but it's just something that's important to what we do. And also kind of more recent developments, we do a number of really highly targeted therapies, which are really at the cutting edge of oncology treatments at the moment, specifically for neuroendocrine tumors and prostate. So in terms of a typical day in the life for me, the workday is typically from 8 a.m. to 5 p.m., which is nice. And it's fairly rotation dependent. So if you're on a general nuclear medicine desk, you'll do maybe 10 to 15 cases of varying complexity. Bread and butter are things like bone scans, myocardial perfusion studies, or maybe these wall motion renal scans. And then maybe 2 or 3 times a week, we'll have therapy cases as well. So the bread and butter there are the radioiodine treatments for things like Graves' disease or post-thyroid cancer. But we also do a couple of fancier, I guess, treatments such as radium-223 for people with metastatic prostate cancer, or Lutathera for people with metastatic neuroendocrine tumors. And maybe once or twice a week on top of that, we'll have some very, very minor procedures like sentinel lymph node injections for people that are having lymph node dissections. When you're on PET, you're usually doing about 14 to 15 PET cases a day. And these can be pretty intense because you're doing basically a full head, neck, chest, abdomen, pelvis with the extremities for some people, with superimposed physiologic data on top of that. And these are usually done mostly for cancer workups, but we've also started doing some things for inflammation imaging, such as looking for sarcoidosis or fever of unknown origin. And regardless of what rotation you're on, more days than not, probably 2 to 3 days of the week, you'll also be involved in some form of tumor board or patient management form on top of your daily work. In terms of the call, it's probably highly dependent on where in Canada you are, but in Halifax here, we do 1 week at a time, once every 4 weeks, which sounds like a lot, but it's an incredibly chill call. I think I've been on call 6 or 7 weeks this year, and I've only been called twice. They were both on Saturday during the day, so it was something that wasn't getting me out of bed and messing with my sleep schedule or anything like that. And in Nuke Med, nothing happens emergently. So if you're called about a VQ scan, it's probably going to be 2 or 3 hours before it actually gets done by the time the technologist goes in and gets the radiopharmaceutical prepared and gets the patient over. So nothing happens overly quickly in Nuke Med. So in terms of the pros for nuclear medicine, one thing that I like is that we do a huge variety of studies, everything from those standard bone scans, the standard wall motion studies, the very specific imaging, like looking at people that have excessive tearing and looking to see how their tears drain from their eyes. So there's a lot of cool little things like that that you probably don't think of when you think of Nuke Med. The other thing I like about Nuke Med is that we have some tests that are highly specific to answer specific questions. So for example, we have a test that looks for splenic tissue. So some people will have little lesions in their tail or their pancreas, and they're wondering, oh, is this cancer or is this just some ectopic splenic tissue? We destroy some red blood cells, label them with radiopharmaceuticals, and then inject them into the patient. If that spot lights up, it's ectopic splenic tissue, not cancer. Patient can sleep well at night, done. There's no differential for it. It's very satisfying when you're calling things like that. There is some degree of patient interaction, and I put that in italics. I don't know how well it came across there, but we're all radiologists here, so obviously we don't want to spend our entire days dealing with patients, but we do get some degree of interaction normally on the therapy side of things. So doing consults for radioiodine therapy or Lutathera, but they're usually quick and not overly onerous. We have a massive impact on patient care, particularly in the oncology setting. It's very rare that someone will see an oncologist, be it radiation or medical oncology, without having a PET if they have a diagnosed cancer. We're also kind of what I alluded to earlier at the cutting edge of medicine for therapies. In terms of prostate cancer and neuroendocrine tumors, some of the treatments that we do just cause the tumors to melt away, which are very satisfying to see. There's also tons of job opportunities. I get multiple emails a week from places across Canada that are looking for dual trained physicians, because you can add a lot on the nuke medicine side of things, but being certified in radiology too, you can also help with the radiology call schedule, which people are certainly interested in having help with. But it's not all sunshine and roses. So there are a couple of drawbacks, I think, at least in my mind. And depending on the desk that you're on, there can be a fairly large amount of interruptions, which are mainly the techs checking the cases to see if any additional imaging is required. It's not as bad as being on like an emerge desk or something like that. But if you're someone that just likes to come in, throw on some headphones and rip through the list, that's just something to keep in mind. But when you are on the PET desk, you can kind of do that. I usually go in and throw on my headphones and put on some lo-fi music or something and just do my work and leave at the end of the day. The other downside is that our days in Nuke Med are fairly backloaded, just it's the nature of the beast, because people come in, they're injected with a radiopharmaceutical, and a lot of times they have an hour or 3 hours to just go and do their thing before they have to come back for the imaging, just to give it time to circulate and go where it needs to go. So sometimes if there's any delays in the QC, the quality control for the radiopharmaceuticals, or issues with the camera, things just get pushed back and back, because once the patient's injected, we have to image them regardless when that happens, if it is delayed. Another thing to keep in mind, while I said that there's a ton of jobs available, almost all of them are in the city. There's very few community nuke med departments. There are some that will do things like bone scans and VQs or HIDA studies, but if you're getting into the highly specialized PET CT, PET MRI, or the therapies, you basically have to be in a big city. So if that's not something that you're interested in, that's another thing to keep in mind. And another downside, which I'm experiencing right now, is having to write and study for and pay for 2 separate Royal College exams, which is not overly pleasant. That's everything. My email's here if anyone wants to scratch it down. I know we'll have some time for questions at the end, but feel free to shoot me an email if you think of anything after the fact.
Good night, everyone. My name is Susan. I'm one of the Women's Imaging Fellows at U of T, specifically at Sunnybrook. So I'm going to talk about Women's Fellowship and specifically how the day, usual days at Sunnybrook. And I would talk about some tips for fellows and residents. So basically, Women's Fellowship is a 1-year fellowship program. It's a combination of breast imaging and abdominal imaging. And if you're interested, you can do OB ultrasound as part of your abdominal rotations as well. Why women's imaging? Because basically you have the advantage of combining the 2 fellowships, breast and abdominal fellowship. You would do at least half of them, which gives you basically a variety of the studies in both basically subspecialties. And it gives you broader skill set in terms of diagnostic, because we have high volume and very different and various basically pathologies in terms of breast and in terms of body. And in terms of procedures, we do tons of procedures in breast and also non-vascular on body. So at the end, you would be really comfortable in diagnostic and also procedures. And this is one of the fellowships that we have the most patient interactions. It's I found it rewarding because you can discuss the findings with the patients, you can calm them, you can ask even more history if the providing basically if the MRP is not providing you good history. So that is your chance to go in and just get more info. And in terms of job opportunities, it's one of the highly demanding fellowships. And keep in mind that very recently, actually, government changed the minimum age for OBSP, Ontario Breast Screening Program, from 50 to 40, means that we're going to have more volumes, and basically we need more rads to read those volumes. In terms of Women's Fellowship at U of T, U of T offers 2 slots for Sunnybrook, 3 slots for UHN, and 3 slots for SAMAC each year. For this fellowship, altogether 8. And at Sunnybrook, this is how it goes. So you can choose 4 to 6 months of breast. And your week, when you are on breast, your week is going to be 2 days on MRI, which includes the 2 MRI guided biopsies per day. And 1 day you would be on workups, means that you're going to be on mammo and ultrasound, diagnostic ones. And we have 1 day of RDU, which is rapid diagnostic unit. This is when we basically highly suspicious patients are coming from RDU, suspicious for cancer. And we have our most procedures when we are on our RDU. And we have 1 preserved, 1 academic day per week. We have 1 day of breast MCC rounds, and fellows are responsible to present the cases. We have residence rounds 1 day per week, and sometimes we are asked to present. We have citywide rounds, journal clubs. It depends on which hospital is presenting. We are also asked to present on these rounds as well. And then the other half of the fellowship, it depends on how many blocks you ask for breast. So the rest is going to be body. So 6 to 8 months is going to be body. When you're on body, a week on body, you would have at least 1 day for MR and 1 day for ultrasound, and the rest is going to be for CT. Any procedure on their ultrasound guide or on their CT guide is going to be done by the fellow. So we are really hands-on in terms of non-vascular procedures, and 1 preserved academic day. As I said, in terms of procedures, specifically at Sunnybrook, non-vascular procedures are done by abdominal/women's fellows. So we are the same as abdominal fellows at Sunnybrook. In terms of ultrasound guided biopsies, CT guided biopsies, their drainages, whatever it's needed, it's going to be us, and it's not IR fellow. We have specific fellow rounds, CT ultrasound 1 day per week, MRI rounds 1 day per week, and we have teaching rounds for fellows on Wednesdays every 2 weeks. We have multiple MCC rounds. Fellows are responsible to present just on NET MCC rounds, but we have variety of MCC rounds, gynae rounds. We have GU rounds, GI rounds, everything that, every day, basically, we have 1 kind of rounds that we can attend. And we have residence rounds. Some of the residence rounds needs to be done by the fellows, and they assigned us, and we know who is going to be presenting. And we have citywide rounds. It depends on the basically topic. It can be gynae, it can be GI. So that's, again, going to be done by the fellows. At Sunnybrook, we can choose not to have any OB ultrasound, or if you're interested, you can have up to 2 blocks. And it's basically we're going to be involved in high risk OB ultrasounds. Again, variety of abnormalities, and we have very broad spectrum of abnormalities on those days as well. In terms of research, so we need to do 1 project, and at the end of the year, we need to have full manuscript. So some tips: start early, because at Sunnybrook, you need to have your project. Then you would be basically those academic days, it's going to be given to you when you have the project. And try to approach to research-oriented staff that they can basically walk you through to getting your REB sooner, and then a doable basically project during your fellowship, because it's a very short time. It's just 1 year. So you need something to be feasible in a year. And this is about the research. And then a college schedule at Sunnybrook. One thing that I want to mention about the blocks that we do at Sunnybrook is that we do basically random breast and body. So it's not 6 months of breast, 6 months of body. It's going to be randomly basically assigned to us. So, and then in terms of college schedule, we are on the same pool as the abdominal fellows. We usually have 4 abdominal fellows, and then it's 2 of us. So 6 of us is going to be covering the call, regardless of the block that we are on. And so our call starts from Friday, and it goes to the next Thursday. Basically, we start 2 p.m. to 10 p.m. on Friday. We cover the weekend 8 a.m. till 10 p.m. And then Monday to Thursday, 2 to 10 p.m. So we are responsible to read CTs, ultrasound, and X-rays from Emerge and from inpatient. So when we are on call, we are not responsible to read outpatient CTs. And in terms of annual vacation, we have basically 2 weeks every 6 months. So 2 weeks of the vacation should be from our breast blocks, and 2 should be from our body blocks. And 1 week Christmas or New Year, either that you want, you can have that week as well. So this is something that keep in mind that at Sunnybrook, so basically when we are halfway through our fellowship, most of us know when we are heading next. So in terms of our job, so for the second half of our fellowship, basically, we can ask the staff to help us to basically fill our gaps. If anything specific that we need to learn, like in terms of diagnostic or procedure for the job that we're heading to, they are really good to help us through it. For the residents, I have some tips for residents as well. So try to find your personal interest, because when we apply for our fellowship, we are basically halfway through our PGY tree, and it's like when you look back, it's not a long time to decide about the fellowship that you're heading to. So even starting as your PGY2, try to find your personal interest and be hard worker and enthusiastic on any rotation that you go, because basically you don't know at the end of the day which fellowship you would end up doing. So just try to be known as a good resident, and try to find a mentor when you're early on your residency. It can be a staff, it can be a fellow that you know, or a senior resident, because it's really helpful in terms of your studying, Royal College exam, and also your fellowship, and then maybe your future job. It's really helpful to have someone to walk you through and help you. And in terms of application for women's imaging at U of T, you need at least 3 reference letters. It's not mandatory, but it's nice to have 1 reference letter from a breast staff and 1 from the abdominal imaging staff to just, show you that you are basically interested in both and somebody knows you in both fields. These are from me, and this is my email address. If you have any questions, I'm happy to answer you, and you can reach out anytime that you want.